Oh, I know.
And there you stay.
So that's how I became.
That's like a little pick-me-up that I needed before I could even talk. Thank you.
You're very welcome. I'm always here to oblige.
The obligatory Noah picture.
Mm-hmm.
Guess I'll move over and.
Yeah. Angela?
Yes.
So is it all now open?
Yep, I just unmuted it. Yep, you did.
Okay. Yeah, I'll tell us.
They are finishing interviews and will be up here in a few minutes.
So people can hear me, right?
Yep.
Hi, welcome everyone. It is my pleasure to introduce Dr. Sylwia Kaeding as a speaker for our today's endocrine special grand rounds. Dr. Kaeding is currently an endocrinology fellow, second year fellow at UW-Madison. She received her BA in biochemistry and Spanish from Lawrence University. And she completed her MS in physiology at University of Michigan. And she received an MD from Chicago Medical School. And she subsequently completed her internship and residency training from Hennepin Healthcare in Minneapolis, Minnesota. And she is quite fluent in Spanish, Polish, and has working knowledge of German, along with fluency in English, as you will hear. She has clinical interest in thyroid diseases. We are interviewing her for our open position in endocrinology. So here she is, Sylwia, welcome.
Thank you so much for that warm welcome. I'm very excited to be here and give you my talk today. I titled it to T3 or not to T3. That is the question. And of course, it's a play on Shakespeare. I thought it was very apt to highlight some of the dilemmas that we have when considering liothyronine for hypothyroid patients. So without further ado, I want to start off by saying I don't have any relevant disclosures. And I thought I'd kind of do this little vignette that I found in an article that kind of exemplifies a patient that we commonly see in our practice. So this is a patient account of her struggle with hypothyroidism. So she says, I was diagnosed with hypothyroidism 15 years ago. Finding a treatment that was effective for me was difficult as the 4 doctors I visited just wouldn't listen to me. There was an established treatment, levothyroxine. Do it and we don't want to talk about it. Another doctor recommended a mixture of T4 and T3. After 2 weeks, my 10-year clinical depression disappeared. I lost 30 pounds with minimal effort and I felt great with no side effects. I've considered a success from that time forward. On combination therapy, I'm doing better. So I think we get this referral very commonly, and it just highlights that there are a subset of patients who don't do well in conventional therapy with levothyroxine, and there is a subset of patients that do derive benefit from being treated with combination therapy. So with looking at specific numbers from surveys, the numbers of how many patients are dissatisfied with levothyroxine can vary. From one article, I found that 10 to 15% of patients, they do not regain their well-being after being treated adequately on levothyroxine monotherapy, and that's with the standard of having the normalization of their TSH. They can have persistent symptoms such as fatigue, weight gain, and mood changes. And there's some patients, but not all, that may feel better while taking combination therapy consisting of both levothyroxine and liothyronine. So that's what my talk is devoted to. And of course, when thinking about how to treat hypothyroid patients, I always want to look back to the guidelines. And so what does the ATA say about this? And there is a small section, and read it how you will, but they say there is currently insufficient evidence to support the routine use of a trial of combination of levothyroxine and liothyronine therapy outside of a formal clinical trial because of their uncertainty in the long-term risk-benefit ratio of the treatment and uncertainty as to the optimal definition of a successful trial. So I highlight the words routine use there. They don't say that it's not an option, but just that for all comers that they wouldn't suggest starting off with the combination therapy. So to kind of guide my talk moving forward, there were the 3 main questions that I asked myself preparing this talk. So first, how did we kind of arrive at our current standards of treatment? How did we get to this point where we do this approach of treating hypothyroid patients? And then I thought to look at the trials and what they say about doing a combination therapy. And then thirdly, to end on, is there a role of liothyronine therapy in the treatment of hypothyroidism? So with that first question, of course, I feel it's always helpful to go back to the basics to have that good understanding of just physiology of T3 in healthy humans. So this is, of course, our schematic with the pituitary regulation of liothyronine, or excuse me, of T3 production. So as we know, the thyroid gland is responsible for 20% of the daily T3 production. The bulk of hormone production from the thyroid gland is T4, and the majority is then thereafter converted by the peripheral tissues into T3 by deiodonases. So the ratio of T4 to T3 in healthy humans is 14:1. Depending on which study you read, that may be 16 or 15:1. And of course, the tissues, liver, muscle will then convert through the use of deiodonases, the T4 to T3. So, and then of course, there's different pharmacologic considerations. And so with how we treat it depends on what we have on the market. So of course, we're all very familiar with levothyroxine, which is T4. And we have, of course, different dosing ranges available on the market where we can do doses as small as 25 micrograms up to 200. So there's a variety of different pill sizes in the interim. And of course, dosing, we do daily dosing because of the long half-life of 7 days of levothyroxine. And of course, we know absorption can sometimes be an issue where 80% of the medication is absorbed. Cytomel, liothyronine, or T3, on the other hand, is a little bit different. There's only 3 different pill sizes, 5, 25, and 50. Its half-life is much shorter. And really to account for that short half-life, the dosing would have to be multiple times a day to really counteract that peak effect. And absorption is much better in contrast to levothyroxine. I won't speak so much about desiccated or combination therapy such as Arbor thyroid. For that reason being that the ratio is not physiologic, the composition is more of a 4:1 ratio. So it's not really the standard of care. And then another side note is just how we measure, how we use our laboratory assays to monitor treatment adequacy. So serum T3 level, it's kind of controversial how we measure and how we interpret. The reason being is that with the current formulations of T3 that we have, we would need to take the supplement several times a day to achieve T3 peaks and troughs. And we have to be very mindful of when we draw this T3 lab in relation to the administration of the liothyronine, because there is that peak level that happens about 4 hours after the administration of the medication. And then this does also have practical considerations too, that T3 peaks can be associated with symptoms having anxiety, tremors, and palpitations. So with that background, I think it's kind of helpful to also know some of the history of how we came to have these supplements, how we came to this point. So it's very interesting that back in the 1880s, that's when thyroid extracts were originally developed. And by the early 1900s, that's where the desiccated thyroid extract became the dominant and commercially available form. It wasn't until the 70s that the levothyroxine became commercially available and became what was the standard of care. It was considered to be safe and effective. And it was really interesting because around this time that this pendulum swung to using levothyroxine, that it was actually very much noticeable that there was anecdotal evidence that some patients just did not feel well on levothyroxine monotherapy and asked to resume desiccated treatment. So there was this one interesting paper from the 70s that I found, and it's just interesting to see that in that experience it says it may be the experience of many clinicians, as has been ours, that a very small group of patients with hypothyroidism are not entirely well on thyroxine replacement alone. It is particularly for these that we found T3 to T4 tablet of value. So, and then of course, in the years afterwards, there has been other data too that has emerged that has really shaped of how we think about what is considered to be euthyroidism too. So I thought it was really interesting to look at NHANES data, where they looked at comparing monotherapy levothyroxine treated patients with matched control groups. And you can see that the main differences that we can see that the patients who are treated with levothyroxine monotherapy have relatively lower circulating T3 levels. So whether or not that's significant is, of course, of debate. There are some people that say that what is the relevance of having this difference of serum T3 to T4 levels? So on the one hand, it can be argued, well, if the TSH is normal, it must indicate that there's higher than normal free T4 levels that will provide extra substrate for deiodination and providing that regulation to TSH secretion, because we do know that TSH secretion is dependent upon nuclear T3 receptor occupancy in the pituitary thyrotrope. On the other hand, there's also this other hypothesis where it speculates that there can be hypothyroidism at a tissue level. So it can be that perhaps that there are some patients who are persistently hypothyroid. Hi, everyone. That there are some patients that are persistently hypothyroid because the tissue levels of T3 are not quite normal in those patients that are treated with levothyroxine. So it then kind of leads into another underlying hypothesis, is that maybe there's some genetic predisposition that would make some individuals then more susceptible to having hypothyroid persistent symptoms. And so with the role of deiodinases, as referred in some of the earlier slides, these are the ones that do the peripheral conversion to T3. So there are differences in expression amongst individuals. And there was one randomized control trial in 2017 that showed that individuals with genetic variations in the type 2 deiodinase, that's the one that's more significant for humans, and specifically those individuals had more benefit from combination therapy. And they also did see the same with a specific hormone transporter protein called MCT10, but the sample size was very small and only looking at patients with autoimmune hypothyroidism. So, and of course, there's other explanations too for these persistent symptoms. Of course, it's always important for us to exclude alternate etiologies and not be locked in that it's truly just hypothyroidism. Of course, in our practice, we see a lot of mimickers. So we always want to exclude, for example, that it's not menopausal symptoms, not anything else going on. Of course, there could be comorbid psychiatric illness. So there's this somatic symptom and related disorders hypothesis. So under this diagnosis, it states that persistent bodily symptoms associated with significant functional impairment, psychological distress, and high healthcare costs. And it can be accompanied by anxiety or depressive disorders, and having severe distress about physical symptoms. And then another hypothesis, specifically with our patients with primary hypothyroidism for autoimmune causes, is that there could be a negative effect of autoimmunity on the quality of life. And it could be from a direct effect of the TPO antibodies. So still a lot to be learned about the causes of persistent hypothyroidism. So now shifting gears and talking a little bit more about the combination trials. I thought this was a very helpful figure to kind of put into bigger picture how all these studies look like. So there is very much heterogeneity in the design of these randomized control trials, from the target population to the endpoints, how they dose liothyronine, T4, and how they design their study. And so you can see that from the target population, it could be someone, for example, who has primary hypothyroidism from a thyroidectomy, to someone who has autoimmune hypothyroidism versus someone who has all sorts of causes of hypothyroidism versus those who are dissatisfied with their therapy. And of course, there's pros and cons from each of these strategies of how we choose the patient. If you can think of someone who had a thyroidectomy, they have no residual thyroid tissue. And so there's not as many confounders that way. For example, if you were to choose someone with just having autoimmune hypothyroidism, where they could potentially have other comorbid autoimmune conditions. On the flip side, if you choose someone who has just a post-thyroidectomy patient, that is a much smaller patient sample size and may not apply to just a broader population in general. From the endpoints, you can see that there's also heterogeneity there, where do we look at quality of life improvement, and then of course, how do we define that? Do we do laboratory-based endpoints? Do we judge what the patient preference is? That has been an underlooked area in hypothyroidism, where unfortunately preference of what the patient wants to do for their treatment is not as much factored in to our management. And then of course, how we dose the medication is important too. As we'll see, a lot of these trials, they have dosed liothyronine once daily, and as alluded with the earlier slides, the dosing would be better in a BID or a TID fashion to avoid that peak effect of liothyronine. And then, of course, a study design. Do we do a double blind? Do we do a crossover trial where we switched from formulations down the road? So it's not surprising that with the types of trials that we have, it's hard to group the data as an aggregate and draw conclusions because they're so diverse in their design. So just to kind of put some highlight overview points, there have been dozens of publications looking at the combined effect of treating with LT3 and LT4. However, if you narrow that subset of trials and look at and exclude desiccated thyroid extract, if you exclude studies where they didn't do a randomized control trial, that narrows down the number of studies to potentially 15, 16. If you further select for studies that have done that physiologic T3 to T4 ratio, that lowers the studies again. And in fact, most of the studies that I saw, they really favored the ratio more towards LT3 than LT4. If you look at those trials that have looked at specifically for the patients who are symptomatic on LT4, that of course reduces the sample size down further. So definitely a lot of heterogeneity, as we can see. It's not surprising then that when we take all these as an aggregate, the studies as a large do not seem to support the efficacy of combined therapy with LT4 and LT3. So I wanted to highlight just a few examples of ones that I thought were better designed and I feel could apply to us in our practice. So there was one trial in 2005 where they did do physiologic combinations of LT3, LT4. It was a very small study, only an N of 24. It was based in Spain and enrolled women specifically with overt primary hypothyroidism. And in their methodology, they did do a double-blind randomized design where they compared treatment with 100 micrograms of LT4, that was considered the standard, versus a combination in a ratio that was 15:1, so when it came physiologic. And their treatment period on each treatment was 8 weeks long. And what they found, really that there was no difference in more the quality of life, the functionality of the treatment options. However, they did see an objective preference that patients did prefer the combination treatment over the monotherapy. So that was a highlight from that study. And then more recently, this 2021 trial by Shakir et al. This was one that inspired my talk because it was so groundbreaking in the research that they chose to do. So they did have a revealing sub-analysis that I'll get into, but their method was looking at doing a prospective crossover trial, looking at 75 hypothyroid patients and used 3 different treatment options. They did monotherapy, combination therapy, or desiccated thyroid extract. And in their study design, they had specific ways that they would titrate the doses. Overall, their ratio tended to be a little bit more skewed in T3, it was maybe closer to 9.5 to 1, but still not as extreme as some of the other trials that I found. And what was really fascinating about this trial is when they broke down their data on the quality of life metrics, and they looked at the patients that were having the most symptoms. So that when they analyzed the data for just those patients that had one-third most hypothyroid symptoms, they found that those patients benefited the most from combination therapy. So on this graph, you can see that more symptoms are favored to the right. When they looked at the combination therapy, they saw that the thyroid symptom questionnaire did have improvement. And they found similar findings with the visual impairment index, the depression index, and the general health questionnaire. So this was very fascinating. It just, like part of the conclusions and some of the speculation that they had is that maybe part of the reason why we're missing some of that benefit from combination therapy is that we're not selecting, we're not analyzing for the patients who stand to gain the most from combination therapy. So it may have been that the numbers in the trials have not been robust enough to detect the response in sufficient power. And then there's another side note, with some of these studies, as we can see, the duration has been fairly small. We don't have very robust longitudinal data to see longer term outcomes of combination therapy. So kind of been synthesizing all this to kind of think, well, then what do we make of all this? Is there in fact a role of T3 therapy in the treatment of hypothyroidism? Certainly, there has been this swinging pendulum, and I thought this kind of puts that historical perspective, interestingly too, where we can see the distant past, where when we all had was desiccated thyroid extract. Of course, that was the standard in the early 1900s. And then in the 70s, the pendulum swung to just then doing monotherapy because that was available. And now it kind of seems that now in the 2000s, we're now shifting more towards a potential role of combination therapy. And maybe there'll be perhaps a physiologic therapy and individualized therapy where we account for some of these patient-specific factors. So it was very interesting then to see that there was a joint consensus statement released just in 2021 with the American Thyroid Association, the European Thyroid Association, where they do acknowledge some of these findings, and they say in their statement, despite the negative results of the trials that have been published thus far, both patients and physicians remain interested in prescribing combination therapy. And what they say, the possibility of undiagnosed psychological comorbidities should also be considered. Based on our current knowledge, specific biochemical measures such as reverse T3 do not seem to be valuable. And they do say patients who are pregnant, of course, we would not be selecting for combination therapy. Patients who have arrhythmias or established cardiovascular disease would also should not be considered for this combination therapy. And they do acknowledge some of these trials, and they say that when we do offer combination therapy, that it should be explained that this is a non-standard treatment for which the risks are unclear. And there's that potential for accelerated osteoporosis, atrial fibrillation with stroke risk. And it should be made that this is a trial, so that there should be a time-limited approach where you give 3 to 6 months, for example, of trialing the combination therapy. And if there's no gain benefit within this time, then the therapy should be discontinued. And they, to that end, they recommend assessing the response with a questionnaire. They, of course, do recommend that if combination therapy is to be pursued, that it be dosed in a physiologic manner, so using a ratio of 13 to 20 to 1, so that which mimics the physiologic thyroxine, T4, and T3 secretion by the thyroid gland. So if we kind of put those numbers in perspective, then we would have a dose of LT3 that's 5 or 10 micrograms for patients who take anywhere between 100 to 200 micrograms of levothyroxine. So then they do address the issue of monitoring. As alluded, T3 measurements can be challenging, so there is a variation in serum T3 levels with our current preparations. There is that peak serum T3 level that happens 2 to 4 hours post-dose. So they do say that if we do have TSH that's maintained in reference range and the T3 level that's maintained within reference range, they do consider that to be likely a safe dose. But they do point out that not all patients will be satisfied within that range. And they do say that if you do plan to continue liothyronine treatment as a long-term basis, that there is some monitoring that takes place. So they specifically say that you monitor pulse, EKG for AFib at each office visit, along with a 3-year DEXA scan in post-menopausal woman. And this is, of course, expert opinion. There's not anything specifically evidence-driven, but that's the consensus that they came up with. And then as far as future directions, within that same consensus statement, they all do agree that we can do a better job of designing our clinical trials. There is, of course, a need for a carefully designed trial where we can identify some of these benefits and risks for our patients. They do seem to suggest that genetic testing could be a potential tool to help identify patients who would benefit the most and who may not respond well to levothyroxine. There's also an interesting work being done about designing different types of preparations of liothyronine. So it has been recently published a phase 1 trial looking at a slow release liothyronine. And it has this name called polyzinc liothyronine, PZL. The goal with that is that if we have a slower release T3 formulation, hopefully that would mitigate some of these peaks and rises that we see with T3 levels, and then hopefully avoid some of the potential problematic symptoms from that. So to conclude, there is that small subset of patients who do feel unwell on levothyroxine monotherapy, and there's a lot that we have learned and a lot that is still to be learned. But there are pretty promising trials comparing levothyroxine monotherapy with combination therapy. And currently where we see an aggregate, those have not focused so much on the patients that have been very much symptomatic and who could potentially stand to gain the most from combination therapy. And there is that recent consensus statement that it does suggest that trial of combination therapy with very much specific monitoring parameters for the patients who do remain symptomatic from their hypothyroidism. So I probably finished faster than expected, but I welcome your questions and thoughts about this topic. I hope that you guys found this beneficial.
That was very nice talk. Oh no.
Sorry. I guess I'm not supposed to unmute. That was really fantastic. Thank you very much. We can take some questions. I'm also monitoring the chat.
Please, okay. So you pointed out in that consensus statement, I mean, the expert opinion about EKG monitoring.
Yeah.
I mean, I guess my question for you in the comment, there have been some other studies, aggregates of, I think, the Scandinavian data that show that there wasn't any increase in the available trials of AFib or osteoporosis or fractures. I mean, with that in mind, does it seem reasonable? I mean, EKGs every visit.
Yeah, that's a very good point. I guess I can kind of see pros and cons. I think with one of the points, or one of the things that I noticed with a lot of these combination trials is that the bulk of patients are women who may not have as much CV risk. So I kind of wonder then if we were to extrapolate and include more men who may have CV disease burden, maybe that would become more apparent. But yeah, I think that's an interesting thought. I guess with EKGs, they are, in terms of healthcare costs, not as more pricey as some of our other interventions. But yeah, I can definitely see both sides of the arguments that maybe there is potential risk if we were to expand and include more men with hypothyroidism. Yeah.
If the T3 is in the normal range before you start it, what are you aiming for when you're monitoring as far as changing the T3 level?
Yeah, that's a good question. So there's, of course, a lot of debate there too about how we interpret the T3 level because of the limitations with our assays. So there are some experts who recommend potentially then doing a T4 to T3 ratio rather than the absolute T3 number. I don't think there's quite clear consensus whether or not that T3 level is quite necessary, but I think in terms of this 2021 consensus statement, the way that they phrase it and the way that I've interpreted it is that it should be maintained within the normal range, that we don't become super therapeutic from the T3 standpoint.
It's just tricky if it's in the normal range already. How do you maintain it more in the normal range?
Yeah, I guess just maybe the thought is then that you don't exceed and make it.
And it's tricky too, because as you pointed out, you can make it whatever you want it to be. If you check it an hour after you take it, it's going to be high. If you check it 10 hours later, it's going to be low. And if you check it, so you could kind of, trick it into being whatever.
Yeah, exactly. Depending on the time of the measurement. Yeah. Yeah.
So you mentioned that you looked mostly at the studies that used the physiologic T3 to T4 ratio. Is there a difference in outcomes from studies that have not used a physiologic ratio?
Yeah, that's a great question. There is such a wide spectrum that even if you look at the studies where it was not a physiologic ratios, there are some that will say like, oh, minor quality of life improvement. Others that will say no. So even within that subset, there's heterogeneous.
Okay.
Yeah.
And then I have another question about this slow release liothyronine. Would that still be a daily pill?
Oh, that's a good question. So I think the intention is a daily pill. I don't recall if in their phase 1 trial with the healthy volunteers if they dose it that way. I believe they did. Mm-hmm.
Do you know in that sort of larger study that you spent the majority of the time talking about, do you know in the people that saw the most benefit, they did any subset analyses where they did any genetic testing?
Yeah. So they did do polymorphism testing for that type 2 deiodinase. So it's like this 3-amine 92 alanine polymorphism, and they did not find any benefit. Yeah. And there's also a lot of discrepancy with that finding too, but in this particular trial, they did not find it.
So what was the prevalence? Is there any idea? I think you also talked about another study there. So what's the prevalence of any polymorphisms or mutations in that? I'm sure that polymorphisms exist in any enzyme you test, but you have to find that pathogenic, if you call, like whichever one will be associated with non-response to levothyroxine therapy. I suppose all the sample sizes are so small.
Exactly. Yeah. I don't recall that off the top of my head. Yeah. Yeah.
The other question I have is you mentioned about in pregnancy, not trying to do this combination therapy. So what is if someone is already on a combination therapy, they are trying to get pregnant or do get pregnant, is there any recommendation on that as to do we now stop and change them to levothyroxine easier to monitor, or what are the?
Yeah, I think there's very much consensus statement that because in pregnancy the T3 will not cross and will not provide the treatment that in that particular setting that you do monotherapy for the duration of the pregnancy.
And there is an ongoing recruiting trial of T4, T3 in, I can't remember if it's the UK or Scandinavia. I think it's the UK. So their plan is to have a large, hundreds or 1,000 people in a randomized controlled trial that's recruiting currently.
That's good to know, yeah.
Are they doing just general hypothyroidism or not?
Forgot what
I was curious.
but I mean, it's, yeah, they, in one of these talks at Endo, they talked about how it's recruiting. I think it's the UK.
Yeah, I think it's probably, the benefits are probably going to be limited to that small group of people who do not respond to. Is there any sex difference in the people who do not respond to levothyroxine?
Yeah, that's a good question. I feel like with the trials and the way they are, they're predominantly women. I don't think they have enough power to really differentiate between sex differences. So in this particular trial, for example, with the 75 hypothyroid patients that they included, it was 58% women. So kind of skewing more on the gender towards women. And I don't think that they analyzed specifically male versus female, if that makes sense.
For those of you who see thyroid a lot in outpatient practice, is that your experience that this kind of quote-unquote non-response is more limited to more common in women, or is that not?
Absolutely.
Yeah.
Absolutely.
So is there any estrogen effect? I mean, is it more postmenopausal or premenopausal women?
I think it's both. It's both. I think it's pretty much equal across the ages. Yeah.
I have a question. Can you hear me?
Yes.
Yes.
So as you know, assays vary from platform to platform, institution to institution. And whenever you have a ratio, of course, you can amplify these errors. So in your readings, did you see, if you're going to use the ratio of T4 to T3, what the variation is between different ways to measure it?
Oh gosh, no, I did not look at that. Yeah.
That's a very important, interesting question. Good project.
Yeah.
So, thank you, Rochelle. I don't really see any other questions in the chat. Anyone else has questions here? I think that's it. Good job.
Thank you.